All right, books open, focus on. Welcome back to the deep dive. Today, we have a very specific, very high-stakes mission. We're not just exploring medical science for the fun of it today, though let's be honest, we usually are. Today is about survival. Specifically, surviving the MD anesthesiology exams.
That is the correct mindset. We are shifting gears from casual curiosity to high-yield, exam-focused precision.
Right.
Consider this your final revision session during the drive to the exam hall. If you can't articulate these concepts clearly to an examiner who hasn't had their morning coffee yet, you aren't passing.
We've got a stack of heavy hitters on the desk today. We're talking Miller's Anesthesia, 10th edition, Morgan and Mikhail, O's Intensive Care, and some very specific exam-oriented notes like Kaushik Jothanau.
All the classics.
And we are tackling the absolute nightmares of the operating room.
Yeah.
Blood and fluid management disasters.
To be precise, we're covering the two most critical, life-threatening complications that examiners love to grill you on.
Why is that?
Because they require immediate, complex decision-making. We are talking about transfusion-related acute lung injury, TRALI, and the physiological spiral of intraoperative coagulopathy.
These are the heavyweights. If you get a long answer question or a Viva station on these, you need to be bulletproof.
Absolutely.
So our mission today is to break down the pathophysiology, the diagnosis, and the management, but strictly through the lens of how to answer the question to get maximum marks.
Precisely. We aren't just chatting, we are structuring a model answer. We need to cover the definitions that the consensus guidelines demand, the specific trials you need to quote to look well-read, and the fatal traps you need to avoid falling into.
The ones where the examiner tries to lead you down the garden path.
Exactly.
Okay, let's dive right into Part A. The first beast, TRALI, transfusion-related acute lung injury. Why is this the headline act? Why does this specific pathology get so much real estate in the textbooks?
It's the headline act because statistically and historically, it is the leading cause of transfusion-related mortality. It kills people. So if you're asked to write a short note on transfusion reactions, TRALI has to be the centerpiece of your answer. It's the one that catches anesthesiologists off guard because the patient isn't necessarily bleeding to death, they're suffocating.
So let's set the scene for the exam paper. The question is, write a short note on TRALI. How do we define it? I know we can just say lung gets wet after blood. We need the precise Miller-approved definition.
You need to be extremely precise here. According to, the consensus definitions, TRALI is defined as a new acute lung injury.
New being the key word.
New is the key word, and it occurs during or within 6 hours of a completed transfusion.
That 6-hour window is critical.
It's the golden rule for the definition.
Yeah.
If it happens at hour 7, you're looking at a different pathology, maybe ARDS from sepsis or pneumonia. But for TRALI, it must be within 6 hours.
And there are physiological criteria, too.
Yes, you have to state that there is hypoxemia, specifically a PiO2 to FiO2 ratio of less than 300 millimeters of mercury, or an oxygen saturation of less than 90% on room air. You need to include those numbers.
And crucially, the exclusion criteria. What is it not?
That is arguably the most important part of the definition. It is non-cardiogenic. There must be no evidence of left atrial hypertension.
So it's not the heart's fault.
It is not the heart's fault. If the left atrium is overloaded, that's transfusion-associated circulatory overload, or TACO. Trial is about capillary leak, not pump failure. If you don't make that distinction immediately in your opening paragraph, you've lost the examiner.
Okay, so we've established the definition. New acute lung injury within 6 hours, hypoxic, and not the heart. Let's look at the numbers. How common is this, really?
In an exam answer, you want to quote statistics to show you've read the literature. The incidence varies, but a safe, citable number from Kaushik is approximately 1 in 5,000 units transfused.
Okay, 1 in 5,000.
But Miller points out that in specific surgical populations like cardiac or transplant surgery, it can be as high as 1.3% to 3%.
That's actually a pretty significant variance.
It is, and it's probably because it's vastly underdiagnosed.
Yeah.
Mild cases often get written off as just fluid overload or a bit of atelectasis.
I see.
What's more important for the Viva is knowing which products are the culprits.
Right. I think the common assumption is that blood is blood, but the risk profile isn't equal across the board, is it?
Not at all. The risk is directly tied to the volume of plasma in the product.
Ah.
So fresh frozen plasma, FFP, and platelets are your high-risk products. They contain the highest volume of donor plasma.
Impact red blood cells.
PRBCs are lower risk but not zero risk because they still contain a small amount of residual plasma.
And there's a specific donor profile that comes up in every single textbook discussion on this.
The multiparous female donor.
Right. Why is the multiparous female, a woman who has had multiple pregnancies, such a specific risk factor for the recipient developing TRALI?
This gets to the heart of the pathophysiology. During pregnancy, a mother is exposed to fetal blood, which, carries the father's antigens. Her immune system sees these as foreign.
And makes antibodies.
And develops antibodies against human leukocyte antigens, HLA, or human neutrophil antigens, HNA.
So her plasma becomes a reservoir of these antibodies.
Exactly. If you take her plasma, which is full of these antibodies, and transfuse it into a patient whose white blood cells match those antigens, you trigger a massive immune reaction.
That's a perfect segue into the mechanism. If I'm writing a long answer on TRALI, this is where I need to score big points on pathophysiology.
Yes. This is a very high-yield section. You can't just write a paragraph. You need to describe the mechanisms clearly. And there are two main theories. A good candidate mentions both.
Okay, let's unpack the first one, the immune-mediated mechanism.
This is what we just touched on. It's the antigen-antibody reaction. You have donor antibodies, anti-HLA or anti-HNA, infused into the recipient. These antibodies then go hunting for the recipient's neutrophils.
And when they find them?
They bind to them, usually in the pulmonary microvasculature. You have to remember, the lung acts like a sieve for neutrophils. There's a huge pool of them just sort of marginated there naturally. This antibody binding causes the neutrophils to activate. And an activated neutrophil is a destructive machine. It releases reactive oxygen species, cytokines, proteases, a whole chemical cocktail.
And the battlefield is the lung tissue itself.
Exactly. This chemical warfare damages the pulmonary capillary endothelium. The barrier breaks down, and protein-rich fluid floods into the alveoli. That's your pulmonary edema.
Okay, so that's the immune theory. But what about the non-immune theory? Because TRALI can happen even without those specific antibodies.
Correct. This is often called the biologic response modifier theory. It's about stored blood. Over time, as blood sits in the bag, cellular breakdown products, specifically bioactive lipids and cytokines, accumulate.
And when you transfuse that older blood,
these substances can directly prime and activate the recipient's neutrophils.
So whether it's an antibody hunting a target or a lipid bomb activating the cells, the end result is the same. Angry neutrophils in the lungs destroying the capillary membrane.
Precisely.
Right.
But here is where it gets really interesting, and this is the gold standard for your exam answer. You need to explain the two-hit hypothesis.
I love a good hypothesis breakdown. It gives such a good structure to the answer. Walk us through the two hits.
Picture a flowchart. Hit 1 is the patient's condition before the transfusion. This patient is not healthy. They might have sepsis. They've just had major surgery, maybe trauma, burns.
So their immune system is already on high alert?
Yes. The pulmonary endothelium is activated and neutrophils are already sequestered. They are primed in the lung capillaries. They are like soldiers waiting for a command. That's hit 1.
Okay, so that's the setup. What's hit 2?
Hit 2 is the transfusion itself. The blood product arrives carrying the antibodies or the bioactive lipids. This is the trigger. This is what tells those primed neutrophils to attack.
So without hit 1, the transfusion might have been harmless.
Potentially. And without hit 2, the patient might have recovered from their initial insult. But you put them together.
And you get TRALI.
And you get TRALI.
That is such a clear way to explain it. Hit 1, patient stress and priming. Hit 2, the transfusion trigger. Result, capillary leak.
If you can draw that as a flowchart in your exam paper, you are practically guaranteeing yourself marks.
Okay, we understand the mechanism. Now let's move to the bedside. We've got a patient in the ICU or on the table. What does TRALI actually look like clinically?
Remember the timeline. Within 6 hours, but usually it's much faster, often within 1 to 2 hours of starting the transfusion. The clinical picture is dramatic.
Sudden onset.
Very sudden. You'll see dyspnea, tachypnea, cyanosis. If they're under anesthesia, you might just see the oxygen saturation dropping like a stone.
And the ventilator alarms start going off.
Exactly. The peak airway pressures shoot up because the lungs are becoming stiff and wet. Compliance just plummets.
And if you look down the endotracheal tube,
you'll likely see frothy secretions. It looks like pulmonary edema because it is pulmonary edema, but there are clues that it's not heart failure.
Like what?
Fever. Fever, chills, and rigors are very common in TRALI because it's an inflammatory, immune-mediated event. You don't typically get a high fever just from fluid overload. Also, look at the hemodynamics. In fluid overload, blood pressure often goes up. In TRALI, patients are often hypotensive.
Right, because of the inflammatory cascade. It's almost like a septic picture.
It is. And then you order the chest x-ray.
The classic whiteout.
Bilateral patchy infiltrates. But again, you need to look for what is missing. In TRALI, the heart size is usually normal. There's no cephalization of vessels, no curly B lines, none of the typical signs of heart failure. It's just a messy, fluffy whiteout.
This brings us to probably the most favorite Viva question in the history of anesthesiology exams, the differential diagnosis, specifically TRALI versus TACO.
This is the big track. TACO transfusion-associated circulatory overload, both present with shortness of breath and low oxygen after a transfusion. The examiner will ask you, how do you tell the difference?
And you can't just say, guess. We need a structured comparison. Let's build a Viva table right now.
Let's do it. Point 1, fluid status. In TACO, the patient is overloaded, the JVP is up, CVP is high. In TRALI, the patient is often hypovolemic or normovolemic. The CVP is normal or low.
Got it. Point 2, blood pressure.
In TACO, typically hypertensive. The vascular system is bursting with fluid. In TRALI, often hypotensive due to the inflammatory shock.
Makes sense. Point 3, temperature.
TRALI has fever. TACO usually does not.
Okay, this is a good list. What about the fluid itself?
This is a great technical point that shows deep knowledge. If you could sample the edema fluid, say from the ET tube in TRALI, it is an exudate. It's protein-rich because the membrane is broken.
And in TACO.
It's a transudate, protein-poor. It's just a hydrostatic pressure pushing water out.
And finally, the biomarkers, the lab test that can help.
BNP, brain natriuretic peptide. In TACO, the heart is stretched, so BNP is elevated. In TRALI, the heart is fine, so BNP is usually normal.
That is a solid list. Fluid stats, BP, temp, protein, BNP. If a listener can rattle those off, they'll ace that station. What about, say, anaphylaxis?
Good question. Anaphylaxis will also have hypotension and hypoxia, but you're looking for other things. Rash, bronchospasm, wheezing is key here, and potentially laryngeal edema. CII is primarily parenchymal lung disease, not airway constriction.
So how do we confirm the diagnosis of TRALI?
It's largely a clinical diagnosis of exclusion. You rule out the heart failure, you rule out pneumonia. There is no rapid lab test.
But you can test the blood.
You can send the donor blood for HLA antibodies, but that result comes back days or weeks later. It helps purely for retrospective confirmation and, donor management, not for the acute resuscitation.
Which leads us perfectly into management, because give Lasix is the knee-jerk reaction to wet lungs in many settings.
And that is the trap. If the diagnosis is clearly TRALI, giving diuretics is dangerous.
Why is it so dangerous?
Because these patients are intravascularly depleted. All their fluid has leaked into the lungs. They are effectively in hypovolemic shock.
So if you give a diuretic,
you drop their blood pressure further and risk organ perfusion failure. You make the shock worse.
So, step 1 in management. Stop the transfusion.
Immediately. Do not finish the bag. Save the bag and the tubing. Send it to the blood bank for testing.
Step 2, respiratory support.
This follows the principles of ARDS management. You need to oxygenate. If they need intubation, you use a lung protective strategy.
What does that mean exactly?
It means low tidal volumes, 6 milliliters per kilogram of predicted body weight, and PEEP, positive and expiratory pressure, to keep those alveoli open and reduce shunting.
Okay, so protect the lungs. Step 3, hemodynamics.
Support the blood pressure. This might mean fluids cautiously or vasopressors if they are hypotensive. Remember, you are treating the shock aspect of the reaction.
And what about steroids? I feel like everyone wants to give steroids for inflammation.
It's controversial.
Yeah.
In an exam answer, you should say corticosteroids are often considered, but there is no definitive evidence they change the outcome.
So stick to the basics.
Stick to the ABCs. Airway, breathing with lung protection, circulation with pressors.
Before we leave TRALI, let's talk prevention, because this is arguably a public health success story.
It is. The incidence of TRALI has dropped significantly because blood banks changed their strategy. The main intervention is male-only plasma.
Which goes back to the multiparous female antibody theory.
Exactly. By preferentially using plasma from male donors or female donors who have never been pregnant or have been tested negative for HLA antibodies, we remove the bullet from the gun, so to speak.
So for the exam, prevention involves donor screening and exclusionary policies for plasma-rich products.
And for the anesthesiologist, restrictive transfusion strategies. Don't transfuse unless you absolutely have to. Every unit is a potential hit too. And documentation is also key. You must report the reaction so the donor can be quarantined.
All right, that wraps up Part A. A devastating lung injury, immune-mediated, distinct from overload, managed with support, not diuretics.
Perfect summary. Now let's switch gears. We're still in the operating room, but now the problem isn't the lungs, it's the surgical field. The surgeon looks over the drape and says, I can't stop the bleeding. It's oozing from everywhere.
This is Part B, intraoperative coagulopathy.
This is a nightmare scenario. We aren't talking about a single bleeder the surgeon missed. We're talking about the complete failure of the blood to clot. This is systemic failure.
In the exam context, where does this fit?
This is huge for massive transfusion questions, trauma scenarios, or liver transplant stations. You need to be able to classify it and manage it concurrently.
Okay, so how do we categorize the causes? I feel like there's a list of 5 things we need to memorize to give structure to the answer.
There is. Always have a structure. Number 1, dilutional.
You've just watered down the blood.
Exactly.
Right.
You've replaced blood loss with saline or colloids, and you've literally diluted the clotting factors and platelets. Number 2, consumptive.
Being used up.
The factors are being used up faster than they can be made. Think DIC, disseminated intravascular coagulation in sepsis or obstetric catastrophes.
Number 3.
Trauma-induced coagulopathy or a TIFE. This is a unique entity we need to deep dive into. Number 4, environmental, specifically hypothermia and acidosis. And number 5, pharmacological, aspirin, clopidogrel, heparin. You know the list.
Let's zoom in on trauma-induced coagulopathy, or TIC, because the old thinking was just we ran out of factors.
Yeah.
But it's more complex than that, right?
Much more complex. This is a very high-yield area for modern exams. You need to understand that TIC happens early. It can happen before you've even given any fluids.
So it's not just dilution. What's driving it?
It's a physiological response to shock. When tissues are hypoperfused, we see the activation of the protein C pathway. And activated protein C is an anticoagulant. It inhibits factors V and 8.
So the body essentially anticoagulates itself.
In a way, yes.
Right.
Simultaneously, you have hyperfibrinolysis. The body starts breaking down clots faster than it forms them. And on top of that, you have the shedding of the endothelial glycocalyx.
Glycocalyx, that's the protective lining of the blood vessel.
Correct. Shock damages this lining, which leads to more inflammation and platelet dysfunction. So if you get a question on ticket, you need to use these buzzwords: protein C activation, hyperfibrinolysis, glycocalyx shedding, and platelet exhaustion.
And this all feeds into the classic lethal triad.
The lethal triad is mandatory knowledge. You should probably draw a triangle in your notes right now.
Okay, what are the 3 points?
Point 1, acidosis. Point 2, hypothermia. Point 3, coagulopathy.
And they all feed each other.
It is a vicious cycle. Let's break it down. Acidosis, specifically a pH less than 7.1 or 7.2, dramatically reduces the function of coagulation proteases. These enzymes are very pH dependent.
And the cold.
Hypothermia inhibits enzyme activity across the board, and specifically, it inhibits platelet function. A cold platelet does not stick. It just doesn't work well.
And the coagulopathy worsens the bleeding.
Which worsens the shock, which worsens the acidosis, which makes the patient colder. It is a death spiral.
So clinically, how do we spot this, aside from the surgeon complaining?
Look for microvascular bleeding. This is bleeding from non-surgical sites. Oozing from the IV insertion sites, bleeding from the gums, mucosal surfaces. If the field is just generally weeping blood despite ligatures, that's coagulopathy.
Now, how do we diagnose it? We have the standard labs, PT, INR, APTT, fibrinogen.
Yeah.
But there's a catch with these in the acute setting.
The catch is time and temperature. Standard labs take 45 minutes to an hour. In a massive hemorrhage, that's an eternity. Also, the lab runs these tests at 37 degrees Celsius.
But our patient might be 34 degrees.
Exactly. So the lab report might say normal INR, but in the cold patient, the enzymes aren't working. The lab result lies to you because it warms the sample up. This is a classic Viva trap.
Dr. Candidate, the INR is normal. Why is the patient bleeding?
And the answer is, sir, the patient is hypothermic, and in vivo enzyme function is inhibited despite the normal in vitro test.
That is a gold star answer. So what is the better way to monitor?
Viscoelastic testing. We are talking TEG thrombolistography or ROTEM rotational thrombolistometry. These are point-of-care tests.
What do they actually measure that an INR doesn't?
They measure the entire lifespan of the clot in real time. From the moment it starts forming to how strong it gets to how fast it dissolves, it gives you a visual tracing.
For the exam, we need to know the terminology. Let's hit the key parameters for TEG.
For TEG, you need to know 3 main things. First, the R time, or reaction time. This is the straight line before the clot starts to form. It reflects your coagulation factors.
So if it's long, you need
FFP. You're waiting too long for the clot to start. Second, the The MA, or maximum amplitude, this is the width of the tracing. It represents the strength of the clot.
And that's about platelets.
It's mostly determined by platelets and fibrinogen. If the MA is narrow or low, you need platelets or cryoprecipitate.
And the breakdown, the end of the clot's life.
That's LY30, or lysis at 30 minutes. If the tail of the graph narrows quickly, it means hyperfibrinolysis. The clot is dissolving too fast. The treatment is tranexamic acid, or TXA.
So our time factors, MA, platelets, fibrinogen. LY30, fibrinolysis. Simple.
Simple and very high yield.
Okay, let's move to management. We have a bleeding patient, coagulopathy is setting in. What is the modern approach? We hear a lot about damage control resuscitation.
DCR is the standard of care. The core principle is to prevent coagulopathy rather than just chasing it. This means limiting crystalloids. Do not pump them full of saline. It just dilutes them and makes them cold.
So we want hemostatic resuscitation.
Precisely. And the key to that is the transfusion ratio.
The famous 1.1.1.
The pure PPR trial is the key citation here. We aim for a 1.1.1 ratio. That is 1 unit of plasma to 1 unit of platelets to 1 unit of RBCs.
Why that specific ratio?
We are trying to reconstitute whole blood. We want to give back exactly what they're losing. If you just give red cells, you're diluting the factors and platelets. 1.1.1 keeps the hemostatic balance and it improves survival.
And let's talk drugs. Tranexamic acid, TXA.
The CRASH-2 trial, you must import this. It showed that giving TXA to trauma patients with significant bleeding reduces mortality. It works by blocking fibrinolysis.
But there's a time limit, right?
Crucial point. It must be given early, ideally within 1 hour, definitely within 3 hours. If given after 3 hours, the study showed it might actually increase the risk of death.
So time is critical. What's the dose?
The dose is 1 gram loading over 10 minutes, followed by 1 gram over 8 hours.
Okay, we've got blood products, we've got TXA. What about fibrinogen?
Fibrinogen is often the first factor to reach critical levels in massive bleeding. In many protocols, if fibrinogen is low, usually less than 1.5 or 1 gram per liter, you give cryoprecipitate or fibrinogen concentrate.
And we can't forget the environment.
Never. You cannot fix coagulopathy in a cold, acidotic patient. You can pour all the FFP you want into them, but if they're 33 degrees, it won't work.
So active warming.
Aggressive warming fluid warmers, force air blankets, turn up the room temperature, and you must correct the acidosis, which usually means restoring perfusion with blood, not just giving bicarbonate.
There's one electrolyte that always gets forgotten in the panic.
Calcium. Ionized calcium.
Why is it so important?
Calcium is a cofactor for almost every step of the coagulation cascade. Factor 4 is calcium.
Right.
But the citrate in the blood products you're transfusing binds to the patient's calcium. So as you transfuse, calcium drops and the heart gets weaker and the blood stops clotting.
So check calcium, give calcium.
It's the fourth pillar of the lethal triad management, really. You should aim for an ionized calcium greater than 1.1 millimole.
And the anesthetic implications specifically.
Large bore access is non-negotiable. You need rapid infusion devices, you need invasive monitoring. An arterial line is mandatory for beat-to-beat pressure and frequent blood gas analysis.
And communication.
Communication is key. You must tell the surgeon, this is not surgical bleeding, this is coagulopathy, so they can pack the wound and wait while you correct the blood.
Let's summarize the management strategy for the exam paper.
1. Stop the bleeding. 2. Damage control resuscitation with a 1.1.1 ratio. 3. Early TXA. 4. Aggressive warming. 5. Monitor and replace calcium and correct acidosis. And 6. Use TEG or ROTEM to guide specific therapy if it's available.
Perfect. Before we close out, let's do a quick exam trap, rapid fire. I'll throw a scenario. You tell me the mistake.
Do it.
Scenario 1. Patient has TRALI, SATs are 88%, BP is 90-50. Student says give 40 milligram furosemide.
Fail. The patient is hypovolemic from capillary leak. Diuretics will cause circulatory collapse. Give fluids or pressors.
Scenario 2. Massive hemorrhage. Labs from 1 hour ago are normal. Student says coagulation is fine.
Fail. Labs are historical and temperature corrected. The patient is likely coagulopathic now. Treat the patient, not the paper.
Scenario 3. Student defines massive transfusion as just a lot of blood.
Needs precision. Define it as replacement of 1 blood volume in 24 hours, or more than 10 units of PRBCs in 24 hours, or more than 4 units in 1 hour. Be specific.
Okay, we're nearing the end of our deep dive. This has been a heavy session, but these are topics that save lives and pass exams.
Absolutely. And if I could offer one piece of advice for the written paper, visuals.
Draw the diagrams.
Yes. Draw the 2-hit hypothesis flowchart for TRALI, draw the lethal triad triangle for coagulopathy, and draw the table contrasting TRALI versus TACO. A clear diagram is worth 5 marks in a long question.
Because it shows you really get it.
It shows the examiner you understand the relationships between the concepts, and it breaks up the wall of text.
So, to recap our mission today, Chiari-II is a non-cardiogenic lung injury. It's an immune attack on recipient neutrophils.
Diagnosis is by exclusion of overload. Look at the BMP, look at the fluid balance. Management is supportive. Ventilate, oxygenate, do not diurese.
And coagulopathy in surgery is often trauma-induced. It involves the lethal triad of acidosis, hypothermia, and coagulopathy.
Management is 1.1.1 resuscitation. Keep them warm, give calcium, and use TXA early.
If you can articulate those points clearly, you're going to crush this section of the exam.
And more importantly, when you are the anesthesiologist on call at 2 a.m. and that trauma comes in or that transfusion reaction starts, you will know exactly what to do.
What's the concluding sentence for the paper?
Early recognition of TRALI and preemptive management of coagulopathy with damage control resuscitation are pivotal in reducing perioperative mortality. That is your concluding sentence.
There you have it, the gold standard conclusion. Thank you for guiding us through the storm of fluids and factors today.
My pleasure. Good luck to the candidate. Stay calm, draw your tables, and remember, don't give diuretics in TRA.
Wise words to drive by. Visualize those diagrams, listeners. You've got this. We'll see you in the next deep dive.